So last talk, I'm going to be discussing selected differential diagnoses in testes and kidney pathology. So what I've focused on here is, again, not to be comprehensive, but it's going to be covering the areas that I find pathologists have sometimes the most difficulty on. Interspersed are some photographs. I love to take photography from various places that I've gone to lecture. This is from Jade Mountain, St. Lucia. So one critical differential in testis is seminoma versus embryonal carcinoma. They're treated differently in terms of their therapy, so it's critical to make that distinction. So classic seminoma, your cells are loosely cohesive, cleared cytoplasm, you see a sprinkling of lymphocytes, nice prominent nucleoli, higher power, again, fairly uniform cells, cleared out cytoplasm. Sometimes nuclei can have kind of a squared off edge to them as well. One of the pitfalls, so that's the kind of the typical seminoma, but to be aware that there's a spectrum of atypian seminoma. There's a seminoma that in the past was called anaplastic seminoma. A synonym was high mitotic rate seminoma, where the cells look more pleomorphic than your usual seminoma. They still have that nice central nucleolus. They still have typically a sprinkling of lymphocytes, but just more pleomorphism, and you'll often see an accompanying increased mitotic figure. Again, loosely cohesive. Just be aware that seminoma may have this more pleomorphic variant. Another pitfall in seminoma, sometimes seminomas can be pseudoglandular or alveolar, kind of a pseudoalveolar growth pattern, where they cling on the fibrovascular cores, giving rise to something that looks like it's trying to make primitive glandular structures. Again, the cells still look like seminoma, and they're not truly kind of tubular formation. Another pitfall is seminoma cells can pagetoid extensively into the reedy testes. The reedy testes is glandular, so once you see the pagetoid cells in the reedy, the pitfall is to call this embryonal carcinoma because you see these cells in glands. The difference is you see normal cells of the reedy and then interspersed the pagetoid seminoma cells. In contrast, this is embryonal carcinoma, much more pleomorphic. You don't get true glands, that would be a teratoma. You get these primitive kind of tubular spaces, but it's a cohesive tumor. Much more pleomorphic than a seminoma, much more irregular nuclei, multiple nuclei, irregular nuclei than a seminoma. Pitfalls with the immuno. So seminoma is OCT3/4 positive, but also is embryonal. So OCT3/4 is a good stain to get you into seminoma and embryonal, basically to get you that group. But then what you want to do, and I in general don't do c-KIT, CD117 for seminomas. My typical stain would be an OCT3/4, that again gets you to seminoma and embryonal. Then look at CD30, which would be negative, and that would tell you that it's seminoma. So those two stains gets you to seminoma. Keratin, you have to be a little tricky, a little bit careful. Seminomas are typically keratin negative, but you can see classic regular old seminomas with scattered keratin positive cells. You still call that seminoma. And I've seen a seminoma rarely with a lot of keratin positive cells. So keratin is not as specific as compared to the CD30 and the OCT3/4. What you don't want to see in a seminoma is keratin positive clusters of cells. When you have a clustered, cohesive cluster, then you have to start questioning, could it be an early non-seminomatous germ cell?